Welcome to this clinical walkthrough on respiratory acidosis, a condition characterized by elevated carbon dioxide levels due to inadequate ventilation. In this video, we'll explore a diagnostic algorithm to help you identify the underlying cause and initiate appropriate treatment. Start by determining whether the acidosis is acute on chronic, or chronic. If the case is acute or acute on chronic, ask, is there wheezing? If no wheezing is present, consider possible ingestion of sedating agents. If ingestion is not suspected, think about neurologic causes. If ingestion is suspected, the likely culprits are alcohol, opioids, or benzodiazepines. Provide supportive care and administer flumazenol or naloxone as appropriate. If ingestion is not the issue, suspect a neurologic etiology. This includes primary central nervous system conditions like stroke, infection, or mass lesions, as well as neuromuscular disorders that impair respiratory drive or muscle strength. For neurologic causes, evaluate for signs of CNS pathology and consider maximum inspiratory pressure measurements. Refer to the neurology chapter for in-depth assessment. If wheezing is present, take a detailed history. If the patient is a smoker with chronic cough and sputum production, consider chronic obstructive pulmonary disease or COPD. Management of COPD includes smoking cessation, short-acting bronchodilators as needed, long-acting bronchodilators, and long-term supplemental oxygen. If the patient reports exposure to a known trigger, asthma is likely. Treat with a stepwise approach, starting from short-acting bronchodilators to inhaled corticosteroids, long-acting bronchodilators, and, if needed, oral steroids. Intubate if the patient shows signs of respiratory fatigue. If weakness is reported without an obvious pulmonary cause, suspect a musculoskeletal limitation to ventilation. For chronic respiratory acidosis, evaluate the patient's smoking history. A positive history again supports a diagnosis of COPD. If there's no smoking history but the patient is obese and hypersomnolent, consider sleep-disordered breathing. If the patient does not have daytime hypoventilation, obstructive sleep apnea is likely. Treat with nightly CPAP and encourage weight loss. If daytime hypoventilation is present, suspect obesity hypoventilation syndrome. Management includes CPAP, weight reduction, and avoiding respiratory depressants. Acetazolamide may be used as a last-line agent. In conclusion, respiratory acidosis requires a systematic approach. Careful history, physical examination, and targeted investigations help guide appropriate and effective treatment.